Hi everyone. Okay, yeah. So it's connected. It's connected. Yes. Hi everyone. Hi everyone. Yes. Yes. So I welcome you all to this ultra rapid revision session. Ultra rapid revision session. And here I will be covering some very important topics, must know topics in your last days. है ना? So don't worry. So we'll be revising all the important topics. All the important topics. And before that, yes, we have a new batch starting on April, in the month of April, for next and for NEET. Only just you can attend all the free classes by just logging on to Unacademy app and using this. Just wherever you are prompted with the code, you can use code Dr. Dixit or Surgery Live. है ना? चलो, let us start with the revision. Let's start with the revision. Okay. So now I have selected a few important topics. Now everything is not important. So today I'm going to start with the revision part of GIT. Yeah. So I'm going to start with GIT. So today we'll do the revision of quick mega revision of GIT. Yes or no? So in GIT I have picked up 7 or 8 important topics. 7 or 8 important topics. Let us talk about them. The first important topic is GI bleed. GI bleeds. Yes. So when you talk about GI bleeding, so we have to understand that we have two types of GI bleeding. We have upper GI as well as lower GI bleeds. Now when you talk about upper GI bleed, there are 3-4 important questions. So this is going to be a very unconventional form of revision. So try to understand. So when you talk about upper GI bleed, uh, thank you, Pooja. Thank you. What are the must know important points? Yes, there are few things which you should know regarding approach. You should know the causes. And students, you should know something about the scores. These are the 3 things which you should have mastery. Now let us talk about the scores first, approach and causes. Yes, let us talk about this now. When you talk about approach, the first thing when you have a patient of upper GI bleed is to follow the protocol of A, B, and C. Yes, she's fine. She's absolutely fine. Yesterday she has put a foreign body in her nose, and then the things were like I had to cancel the class yesterday. So A, B, and C. When you talk about A, B, and C, what do we mean by A, B, and C? A for you have to secure airway. You have to secure airway. You have to secure breathing. So you have to secure airway. You have to secure breathing. You have to secure the circulation. So A, B, and C. You have to secure the circulation. Why these 3 things are very important? Because if you don't secure airway, you will have the least chances of patient survival because of what? Increased risk of aspiration. So don't say that I will start with IV PPIs first. You have to secure the airway. So airway, breathing, circulation, they are the 3 most important things that you have to do. After this, presuming that the most common cause of upper GI bleed is peptic ulcer disease, you have to do 2 things. What is that? Yes, start the infusion of IV PPIs. So PPI infusion, you have to start PPI infusion. This is the first most important thing. The second is decompress the upper GI tract. How you will decompress the upper GI tract? Decompression. Can you tell me, students, how you will go for decompression of upper GI tract? Answer is put a Ryle's tube. Answer is put a Ryle's tube. Don't say that you will go for endoscopy first. Go for Ryle's tube insertion. What is the utility of this Ryle's tube insertion? Can you tell me? Bache, Ryle's tube insertion first of all will reduce the amount of bleeding which is getting collected inside blood, which is collecting inside. And second is it will also give you a clue about the source. So how you can check the aspirate. Yes, evaluation of aspirate. Yes, you will check the aspirate from the Ryle's tube also. What you can check, if it is blood, yes, it confirms what? Upper GI bleed. Yes or no? It confirms upper GI bleed. Yes. If it is bile, last to last year, sorry, PGI Chandigarh has asked question on this. If it is blood, it confirms. If it is bile, you know that upper GI bleed is defined as any bleeding proximal to ligament of treats. Yes or no? So if it is bile, that means up to second part of duodenum there is no source of bleed, because ampulla is giving you bile. And there they don't have bleeding. It's seldom seen that you will have bleeding from third and fourth part of duodenum. So remember, if it is bile only, it rules out upper GI bleed. Are you getting these things or no? Yes. The next is if it is a combination of blood plus bile. If it is a combination of blood plus bile, now here you need a what confirmation? You need a endoscopic confirmation. Or evaluation. This is how the things are done. So whenever a patient is having a whenever the patient is having a presentation of upper GI bleed, this is how you start evaluation. Once the patient is hemodynamically stable, yes, then only you will plan for what? Upper GI endoscopy. Yes or no? Yes. So hemodynamically stable, you will go for upper GI endoscopy. What is the role of upper GI endoscopy? Do you know? Yeah, someone is asking one of the requests. Someone compile all the scores and class. Yeah. I'll do that. Don't worry. बच्चे जो आखिरी के 15-20 दिन बचे हैं ना, 15 days, we have to revise surgery in swab. Yes or no? So every day, either on this YouTube platform or on the special platform, I will be there for you people. Don't worry, Dada is always there. So when you talk about upper GI endoscopy, this is not only diagnostic, this is also therapeutic. Not only therapeutic, it is prognostic also. So let us see how it is diagnostic, therapeutic and prognostic. So now comes the role of some important scores. Yes or no? So let us talk about, this is the basic approach how we follow. What are the basic scores? In upper GI bleed? Yes or no? The first and the most important is the bleed. Bleed score. This score is a criteria. For hospital admission. Yes or no? This is a criteria for hospital admission. Not only this is a criteria for hospital admission, also it is a guide for the prognosis of the patient. This is what is bleed. Now students, bleed itself is a mnemonic. Where B stands for blood loss. Very good, Naveen. Very good, beta. B stands for blood loss. L stands for low systolic BP. Less than 100 mmHg. Then E stands for very good, Naveen, beta. E stands for elevated PT or INR. More than 1.2 times the normal. Yes or no? Yes. And then we have again E. Yes, E stands for erratic mental status. Yes. What else? Yes. What else? D. D stands for comorbid illness. Yes, disease. So here you see comorbid illness. So do you know that if more than 3 parameters, in a layman's language, if more than 3 parameters, yes, more than equal to 3 parameters are positive, One thing you have to know, that you have to go for hospital admission. Hospital admission needs to be done, yes or no? And also this is associated with poor prognosis. Poor prognosis also. So hospital admission and poor prognosis, they are very important. Do you know, apart from this bleed score, we have other score. Yes, Sarvesh, you are right. We go for forest scoring during endoscopy. I'll just wait for 1 minute. I'll get it in front of you. Then there are two other scores. One is a Blatchford score. One is a Blatchford score. There are 8 important parameters in Blatchford score. You don't have to remember, just remember the name Blatchford score, and 0 to 23 is the scoring. 0 to 23 is the scoring. Remember, there are 8 parameters. You have systolic BP, blood urea nitrogen, hematocrit. There are lot many people, heart illness, liver problem. So don't worry about that. Just remember the name Blatchford. No one is going to ask because it's a very complex type of score. The third score that you should be knowing is Rockall. Rockall score. Do you know Rockall score is considered as a best score? Rockall score is considered as a best score. What is important about Rockall score, students? Try to understand how I remember. I'll tell you, you should also remember it like this. If you have a tendency to forget, it is K square. It is K square. C stands for presence or absence of comorbid illness. Comorbid illness. Yes. A stands for age. A stands for age. S stands for, yes, presence or absence of shock. E stands for endoscopic diagnosis of bleeding. Endoscopic diagnosis of bleeding. Yes, of bleeding. And second E stands for endoscopic stigmata of bleeding. So endoscopic diagnosis of bleeding or endoscopic stigmata of bleeding. Stigmata of bleeding. This is how you define a Rockall score. Now, what do you mean by endoscopic stigmata? Endoscopic diagnosis means when you went for endoscopy, you saw that there was active bleeding from that part. That is what is known as endoscopic diagnosis of bleeding. What is the role of, and what is the view of endoscopic stigmata? When you went inside, you did not find anything, but one thing was there. What was that? There was a small clot. There was a small clot, and this clot is a what? Is a stigmata which is associated with recent history of bleed. Since there has been a bleeding, that is why there is a clot. So bache, presence of a clot is not direct indicator of bleeding, but indirectly it tells you that yes, this was a site of bleeding. So this is what is Rockall. Rockall scoring is from 0 to 13. The scoring is from 0 to 13. Next, the most important is your, yes, forest. Everyone was waiting for this, and this is what is forest classification. Forest classification actually is a classification for bleedings associated with the background of what? Peptic ulcer disease. So yes, it is a classification. It is a classification of peptic ulcer disease related bleeding. Point number 1, peptic ulcer related bleeding. Point number 1. The second point is not only this, it is going to give you risk of rebleeding plus risk of rebleeding. Risk of rebleeding. Now, if we talk about forest classification, students, you can go to your examination hall without having breakfast, but don't go without revising what is forest. Student, it is very important. If you expect a question, you have to expect a question on this also. So on one side you write grade, yes, on one side you write remark, on one side you write risk of rebleeding. Risk of rebleeding. Are you getting these things or no? So grade, remark, and risk of rebleeding. Now if you talk about grades, there are 3 grades that we have. Yes, there are 3 grades. Grade 1. Grade 1 is further divided into 1A and 1B. Yes or no? 1A and 1B. What is 1A and 1B? Both of them are having active. Yes, active pulsatile bleed. Active pulsatile. Yes, active pulsatile bleeding. Yes. So what do you mean by active pulsatile bleeding? It's an arterial or venous? Yes, you are absolutely right. It's an arterial bleed, and hence the risk of rebleeding has to be what? High. Yes, high. Okay. Next is active non-pulsatile bleed. Yes or no? Active non-pulsatile bleed. Active non-pulsatile bleed. If you talk about active non-pulsatile bleeding, yes, what does it mean? Sometimes the word ooze is also written. The word ooze is also written. What does it mean? Yes, it means that the bleeding is venous in nature. Tell me whether the risk of bleeding is going to be high or no. Yes, it has to be high. Remember, any active bleeding, the risk of rebleed is always high, high, high. So this also has to bleed. Yes, has a risk of high rebleed. Yes, venous or arterial. If it's a bleeding vessel, it has to be high. Then we have 2. If you talk about 2, if you talk about grade 2, 2 is further divided into 2A. Just give me a minute. Just give me a minute. Okay. Now, what about 2A? We have 2B and we have 2C. We have 2A, 2B and 2C. What do you mean by 2A, 2B and 2C? Remember, it is non-bleeding. It is non-bleeding. It is non-bleeding visible vessel. Students, tell me, if it is non-bleeding visible vessel, will it have a very high risk of rebleeding, low risk of rebleeding or intermediate? Yes, try to understand. If the vessel is visible, the acid of the stomach can erode it and it can cause high. So remember, it is associated with a high risk of rebleeding. Very good Munib beta. 2B, it's the most frequently asked question. It is defined as adherent clot. Adherent clot. 2B is the most important, most frequently asked question. Do you know there are students who often ask, sir, please tell me minimum that I have to study to crack surgery? Answer is, this is the minimum, because if you want to crack surgery and if you want even the last college, yes, the last college where you get surgery is Dibrugarh. Don't take it otherwise. But this is your ticket to Dibrugarh. This is your Dibrugarh special. 2B, you cannot dare to forget. Adherent clot and the risk of rebleeding is intermediate. Do you know a clot has 2 fates? A clot has, Munib, a clot has 2 fates. Either it will heal or it will get dislodged. 2C is a pigmented ulcer base. Pigmented ulcer base. Yes or no? Pigmented ulcer base. And now this is on the right direction. Why pigmentation? Because of hemosiderin. It has bled and that is why hemosiderin is there. That is why pigmentation. So risk of rebleed is what? Low. So 2A high, 2B intermediate, 2C low. And the third is, yes, this is a healed ulcer. This is a healed ulcer. And when we talk about healed ulcer, this is actually low. This is actually this is low. Is that clear? So 2A, 2B, 2C and this is 3. So this is the most important. Forest classification in front of you. Let us move forward. And let us see the classification of GI bleed. When you talk about GI bleed, when you talk about upper GI bleed, yes, when you talk about upper GI bleed, let us quickly discuss the causes also. There are 2 important causes of upper GI bleed. One is non-variceal, and one is variceal. If you talk about variceal bleeds, only 20% of the bleeds are variceal. Remember, 80% of them are non-variceal. 80%. In non-variceal, we will see which is the most common. The most common is peptic ulcer disease. Remember here 2 lines. We will quickly write 1, 2 lines on this also. In peptic ulcer disease, most common source of bleeding. Come on. It's a rapid fire. Most common source of bleeding. Answer is gastroduodenal artery. Most common source of gastric bleed. Answer is your left gastric artery. Let us quickly move to the second most common. The second most common cause is Mallory Weis-Steers. If you talk about Mallory Weis-Steers, the most important thing is This Mallory Weiss tears is a what bleed? Arterial bleed. It's a arterial bleed. Very good, very good. And the answer is left gastric. Left gastric. I always say you have to have that surgical sense. Can you see Mallory Weiss? Arterial bleed. And what is the source? It's the left gastric artery. Left gastric artery. Again, try to understand what is the most common location. Most common location. Answer is it's the breach of mucosa and submucosa. Breach of mucosa and submucosa at cardia 2 centimeter below the G junction. 2 centimeter below G junction. Below G junction. Remember, you are always confused between these questions and peptic ulcer disease. Remember, bleeding, bleeding, bleeding. Yes, bleeding. Bleeding first. Yes. Then it is a peptic ulcer disease. Bleeding first and then vomiting. That's a peptic ulcer disease. Yes or no? Vomiting first. Vomiting first. And then it is a bleeding. Then it is a bleeding. It's a Mallory Weiss tears. It's a Mallory Weiss tears. Is that clear? So if you have to have Mallory Weiss tears as a diagnosis, you'll always have vomiting first and then only bleeding. Is that clear? So if you get a question, young boy going for celebration of launch of product and this and that, he had binge of alcohol and then he had massive bleeding, upper vomitus of bleed. It is what? It is peptic ulcer disease. It's not Mallory Weiss. Mallory Weiss, young boy enjoying the party, having the binge, first vomiting, followed by a massive upper GI bleed. This is what is Mallory Weiss tears. Students, there's a hairline difference. The third is gastritis. The third is gastritis. Gastritis. Yes. When we talk about gastritis, one very famous classification on gastritis. Can you tell me? Yes, let us fly to that place. A beautiful place. Sydney classification. According to Sydney classification, there are 10-11 types. I'm not going to discuss all of them. Yes, I don't have that much of time, but I will remember. I will tell you important. The first is type A gastritis. Type A gastritis. What is type A? Remember, students, 6 A's. What do you mean by 6 A's? It is autoimmune. I will tell you. Bache, Bohav. Siddharth is asking what is the difference between Mallory Weiss tears versus Bohav. Bohav. First of all, Mallory Weiss tear is post binge of alcohol. Bohav is post barotrauma. So they have totally different concept. Mallory Weiss tear is post alcohol binging. Bohav is post barotrauma. Second is Mallory Weiss tears. Mallory Weiss tears, if you talk about, it is below the G junction and it's a partial thickness injury. Bohav is above the G junction and it is a full blown tear. Mallory Weiss is on the right hand side, that is along the lesser curvature, but Bohav syndrome is the left posterolateral perforation. Mallory Weiss is against the close, you can say pylorus, and Bohav is against the close glottis. Try to understand. Mallory Weiss conservative management, Bohav surgical management. Siddharth, is it clear, beta? Is it clear? Okay. So type A, you have autoimmune. And since it is autoimmune, students, it has to be associated with lot of things. Autoimmune, there are autoantibodies. There are autoantibodies against the parietal cells. And once there is parietal cells are destroyed, you will have achlorhydria. Not only this, students, there will be anemia of two categories. One is autoimmune anemia, that is pernicious anemia. This is autoimmune in nature. The second is megaloblastic. We don't have time to rest also. Then we have enteral sparing, and what happens? Enteral G cell hyperplasia. What else you have? Along with this, you have adeno-CA. Remember, type A is associated with adeno-CA. Very quickly, we will see what is about type B. This is H. pylori associated. Not only this is associated with intestinal metaplasia. Yes. Harshit, you are right. Actually, you have that spirit of surgeon inside. Yes or no? Remember, every engineer is a surgeon. Every surgeon is an engineer. We and you, share the same bonding. The only difference is we work with blood, you try to save the blood. Yes or no? It's just because of you people that we are able to do excellent surgeries. Salute to you people. Salute. Harshit, salute to you. Beta. Intestinal metaplasia. Intestinal metaplasia. Yes or no? So H. pylori is associated with intestinal metaplasia. What are the others? I'll just quickly brush it off. You have reflux induced gastritis. You have reflux gastritis. Yes, you have lymphocytic gastritis. You have lymphocytic gastritis. Remember one very important thing about lymphocytic gastritis, that this is the type of gastritis which is actually associated with background of two things. It is associated with H. pylori. Yes or no? H. pylori. Very good, Sarvesh beta. Maltoma. Yes, apart from this, we have erosive, we have stress induced gastritis. Erosive gastritis, we have stress induced gastritis. Let me tell you one very important thing about stress induced gastritis. Do you know, people keep on mugging up what is stress induced gastritis? Stress induced gastritis. Try to understand it in a very small nutshell way. The answer is, when you talk about stress induced, whenever there is stress, your stomach doesn't require blood, your GI tract doesn't require blood, your vital organs require blood. So blood is siphoned from GIT, to the vital organs, and therefore there will be ischemia, and ischemia will cause ulcers. And therefore try to remember, since proximal stomach is the most underperfused part, and that is fundus is the most underperfused part, therefore fundus is the most common type, therefore it is the most common site. Is that clear to everyone? Apart from this, we have many other type of gastritis also. I discussed them in detail, in depth in class, because I take this chapter for roughly around 6 hours. So it will not be wise if I keep on revising everything. Next is, what are the other causes? What are the other causes of GI bleed? What are the other causes? 2-3 minutes we will discuss all the other causes. Yes, the one we have is Dieule-Foys lesion. If you talk about Dieule-Foys lesion, remember only one thing. Can you see this? D. Yes, D. Okay, Dieule-Foys. Dilated. I will tell you, I will tell you, Munib, I will tell that. Okay. Dilated submucosal arteries. Dieule-Foys, dilated arteries at the level of submucosa. Can you see 3 words? DAS, dilated artery, or arteries at the level of submucosa, submucosa. Yes or no? Submucosa. This is very important. Dilated. Remember, this is not a venous bleed. Cardia is the most common site. Cardia, or you can say proximal 5 centimeter. Proximal 5 centimeter is the most common. Yes, most common. Proximal 5 centimeter. Remember, antrum is spared. On endoscopy, what is the classical point that you get? You get to see a nipple-like protrusion. This is classical. The second most important thing is caliber persistent vessel. Yes or no? Yes. The most sensitive area of hypoxia, gastric mucosa also, and Griffith points. Remember, Griffith stomach is always having a better vascularity than the GIT. So Griffith point, if you are asking me, Rishabh has asked, sir, what is the most ischemic sensitive area? Answer is, if you get a question on the segment, it is the sigmoid colon. If you get a question on complete segment of bowel, it is sigmoid colon. Individual point, it is Griffith's point. Individual part in the stomach, it is the mucosa of the fundus, which is the least perfused. Remember, stomach is having exuberant, robust blood supply. No one can even compare. But colon is actually the part which is huge, and here, therefore, there is a lot of problem with the what? Ischemic contractures are there, ischemic strictures are there. Yes, ischemic colitis you must have heard of. So Cushing ulcer is the same. Cushing and curling, there are two things. Cushing and curling are two things. Curling ulcer, you know, curling ulcer, the same concept, same concept. But what is the concept of Cushing ulcer, students? You have, since you have asked me, I'll describe that concept also. देखो, whenever there is head injury, remember there is stimulation of the vagal nucleus located at the floor of fourth ventricle. So the vagal nucleus is stimulated at the presence of, at the level of fourth ventricle. When the vagal nucleus is stimulated, the vagus is stimulated. Vagus is a secretomotor nerve to the stomach, and hence there is a hyperchlorhydria or the peptic ulcer like disease. And that is the reason why in case of curling ulcer you have that same stress induced. But here exclusively Cushing ulcer is exclusively hyperchlorhydria mediated damage, and therefore first part of the duodenum, D1, is more commonly damaged than the antrum, so it's D1 and antrum. If it comes Cushing ulcer, if it comes stress induced gastritis, the answer will always be proximal stomach, that is the fundus. Is that clear to everyone? Yes. Riya Sarvesh ne kya question pucha tha? Proximal ulcer treatment is no, this is not McEwen. I will describe. Okay, so once he has asked, I'll discuss that also. But see, there are three things. No? We have Sendy's procedure. Yes, we have Madliners. McEwen's name, Madliners. Yes, Kelling's Madliners. Yes, or pockets. There are three treatments. No? Pockets, Madliners, Sarvesh, pockets, Madliners, and Sendy's. मैं भी बता देता हूँ. Then we have, so Deulefoy's we have. What else do we have? Come on, what else do we have? We have GAVE. Gastric antral vascular ectasia. Do you know this is also giving you a watermelon stomach on endoscopy. Remember, Deulefoy's is arterial, this is venous, this is dilated venous. Yes, so dilated veins at the level of what? Dilated veins at the level of mucosa, that is at the level of mucosa. Remember, there is a difference between GAVE and Deulefoy's. The location is antrum. There the location was cardia. Here the location is antrum. So this is gastric vascular ectasia, dilated veins at the level of mucosa. What is the closest DD? Yes, but no. Sarvesh, GAVE is venous bleed. Always remember, GAVE is venous bleed. What is the closest DD? Come on, of GAVE. What is the closest DD of GAVE? Answer is portal hypertensive gastropathy. Portal hypertensive gastropathy. Yes or no? Now remember, what is the difference between the location is proximal stomach. The location of GAVE is distal stomach, that is antrum. Here also this is dilated veins. No, that's not meningeals. Meningeals is totally different. Dilated veins at the level of mucosa. How do we differentiate? Since it is a portal hypertensive gastropathy, what is the appearance on endoscopy? Come on. What is that? Snake skin appearance. This is classic and very important. Snake skin appearance is the classical thing. How to differentiate? This is location wise. Apart from this, the appearance, superficial appearance is same. But on endoscopy, this will give you a classical snake skin appearance. That will give you a watermelon stomach. Remember, what about beta blockers? Since it is associated with portal hypertension, beta blockers, they show response. Who shows response? Yes, they show response. Portal hypertensive gastropathy response, whereas GAVE, there is no response. Remember, meningeals is not a risk of rebleed. Is not a risk of GI bleed. Remember, it's not a risk of GI bleed. Apart from these, what are the other things that you should know? Aortoenteric fistulas. Aortoenteric fistulas are also very important. Remember, if you get a question on aortoenteric fistula, what will be the classical profile of that question? Classical profile of that question will be post post-aortic aneurysmal repair. Post-aortic aneurysmal repair. Patient presents with sudden yes, massive upper GI bleed, massive GI bleed, massive GI bleed. This is what is classic. And what is the reason behind this? What is the reason behind this? The reason behind this is infection along the anastomotic side, infection along the anastomosis. This is going to cause loosening of anastomosis. Loosening of anastomosis will result in your pseudoaneurysm, and this pseudoaneurysm will actually rupture into D3. This is the reason. So try to understand. This is the third part of the duodenum. This is the place where actually the aneurysm has been repaired off. This is the place where aneurysm has been repaired off. Yes or no? So try to understand. This is the anastomotic site. If there is infection here, the infection will also erode the wall of the duodenum also, and hence a time will come when this will rupture and this will cause bleeding. Since it is D3 and D4, then it's ligament of Treats. Since it is proximal to ligament of Treats, it has to be classified as upper GI bleed. This is a surgical emergency. You have to explore and repair the leak with the new graft. Next, one very important point is again Haemosuccus pancreaticus. Let us talk about this concept of Haemosuccus pancreaticus. What do you mean by this concept of Haemosuccus pancreaticus? Try to break this term, you will get the answer, boss. What is that? Haemosuccus pancreaticus. Hemo means blood. Blood in succus. Succus means juice. Whose juice? Pancreaticus. So pancreatic juice loaded with blood. How is this possible? This is associated with rupture of pseudocyst into the perisplenic or peripancreatic vessel. So rupture of pancreatic pseudocyst into peripancreatic vessel. And when this happens, this is going to create a lot of things. Yes, very good, Rishabh. Most common arterial or most common vessel is the splenic. It's the splenic artery or maybe splenic vein. It's splenic vein more commonly seen. So try to understand. This is the pancreas. This is the duodenum. This is the main pancreatic duct. And you know that main pancreatic duct is connected with the pseudocyst. And try to understand, if this pseudocyst erodes into the nearby vessel, what will happen? The blood from this vessel will enter the pseudocyst. From this, it will enter into the duct, and from duct, it will go up or down. Since this is ampulla, which is located in the second part of the duodenum, it is proximal to the ligament of Treats. Hence, Haemosuccus pancreaticus has to be classified as upper GI bleed. Hence, it is to be classified. Remember, the investigation of choice is CT angio. Why it is CT angio? Because in the same setting, the treatment of choice can be done. And what is that? Angioembolization. Yes or no? Yes. So with this, we complete the upper GI bleeds. Portal hypertensive things I will discuss in portal hypertension only. Very quickly, we will finish off the lower GI bleeds also. Very quickly, because lower GI bleeds, we don't have many things. We will write few important points, 5 important points in lower GI bleed. If you talk about lower GI bleed, again the bleeding can be colonic or it can be small intestinal. Is that clear or no? Less than 5 to 10% are small intestinal. Remaining more than 90 to 95% are colonic. Most common cause is diverticulosis. Try to understand the ironies. Yes or no? Most common cause is diverticulosis. How many diverticulars bleed? Less than 2% diverticulars bleed. Is that clear or no? So most common cause of lower GI bleed is diverticulosis, but less than 2% of the diverticulars bleed. Most common site for diverticulosis. Most common site for diverticulosis. What is the answer? Answer is, come on. It is the sigmoid colon. Sigmoid colon. Remember, right-sided diverticulars. Right-sided diverticulars, they are actually rare. And where are they found? Asians. And remember, bleeding happens from right-sided diverticulars. And that is the reason why bleeding is not that common from diverticulosis. So right-sided diverticulars, they have a bleeding tendency. They have a bleeding tendency. And that is why. So right-sided bleed, they are rare, and that is why this is the reason. 2-3 important points on diverticulosis. Diverticulosis. Try to understand. बच्चे variceal bleed I will cover in the portal hypertension chapter. Is that clear? When I will teach you the concept of shunts, etc., there I will. Diverticulosis. When you talk about diverticulosis, 2-3 important points. Yes. What is the concept of diverticulosis? It's very difficult to understand, but still I will try to make it clear for you. Students, try to understand, these are the inner circular muscles. These are the inner circular muscles. And then you have the taenias. What is this taenias? Yes, these taenias are the condensed you can say longitudinal muscles. Yes, these are the condensed longitudinal muscles. Now try to understand, in order to supply, keep alive, in order to keep alive the muscle, there should be a blood supply. There should be perforators to these muscles, or no? Yes, and what are these perforators, students? These perforators are known as vasa recta. I hope you must have heard of vasa recta. Yes or no? These are vasa rectas. These are vasa rectas. Now, what is present inside? This is mucosa, colonic mucosa and submucosa. Now, what happens here? With the age, yes, there is hyperelastosis of the bowel. Hyperelastosis of the bowel. So if there is hyperelastosis, therefore there is increased tone. With the age, there is poor peristalsis. Now what is going to happen? There is going to be increased pressure in the lumen. And since there is increased pressure, the point from where the vasa recta is increasing or is moving out, the colonic mucosa and submucosa also pops out. And this is the reason of diverticulosis being called as pseudodiverticular. So why this is a pseudodiverticular? You have to understand, students, why it is a pseudodiverticular, because it is the popping of mucosa and submucosa via the space which is actually meant for vasa recta. Students, it is not the mucosa of the colon which actually bleeds. Can you see at the level of neck? At the level of neck, what is happening? Yes, at the level of neck of diverticula, there is compression of this, compression of vasa recta, and actually this vasa recta gets crushed and it bleeds. So therefore it gets crushed and therefore it bleeds. So bleeding is not from the ulcer, bleeding is not from the mucosa submucosa, it is the damaged vasa recta. Can you see? This is the damaged vasa recta which is actually getting compressed at the level of diverticular necks. The most common complication of diverticulosis, come on, answer me. Answer is diverticulitis. And because of diverticulitis, we have lot of complications. Yes or no? Stage 1, yes, is a pericolic abscess. Yes or no? Stage 2 is a distant abscess. It's a distant abscess. Stage 3, students. Stage 3 is a purulent peritonitis. And stage 4, where it ruptures, this is what is known as feculent peritonitis. This is when it ruptures, feculent peritonitis. Can you tell me what is the name of this classification? Again, a very important classification in front of your screen, and this is what is known as Hinchey's classification. Actually, this is a modified Hinchey's classification. This is a modified Hinch's classification. I'll not discuss all of them. Let us quickly move forward. Remember, important is investigation of choice for diverticulosis. For diverticulosis is not a CT, it's a barium. But investigation of choice for diverticulitis, answer is a CCT, not a barium. It's a CCT, not a barium. Again. Let us quickly move to the second complication. The second most common cause of lower GI bleed. Answer is hemorrhoids. Or if hemorrhoids are not given, anorectal causes, anorectal disorders. Yes. What are the other causes? Yes. What are the other causes? Okay. What are the other causes? Let us talk about the other causes. Yes, because I wanted to enjoy my life. Yeah, I left dance because I wanted to enjoy my life. I wanted to teach everything. I wanted to practice everything. I wanted to start my residency program. I wanted to start my hospital. I wanted a break from that busy, monotonous life. That is why. Here in Unacademy, I am teaching everything. I'm teaching the complete surgery. Whatever I want, whenever I want, how I plan. This is what is the freedom that I have. And apart from that, I'm managing my own hospital. Just now I'm sitting in my hospital. I'll do a surgery after this. So that is what is. So others are malignancies. So there are times when you have to take some calls. Malignancy. The third is, yes, angiodysplasia. This is very, very, very important. Angiodysplasia colon. Angiodysplasia. Now, 2-3 important points about angiodysplasia. What is angiodysplasia? How we manage angiodysplasia? Remember, students, there is no platform better than Unacademy. Let me tell you, I have realized, I have that vision, I have seen. It's time for you also to realize. Very soon you will realize. Very soon we are starting with I'm starting with Unacademy Live also. I should not be declaring that off, but in Unacademy Live we will have a direct patient-based interaction, direct surgery-based interaction from the hospital or from the OT. That is going to give you the cutting edge over the coming exams like next. Angiodysplasia, actually, let me tell you, angiodysplasia is equal to Deulefoys. Try to understand. Deulefoys is equal to stomach, angiodysplasia is equal to colon. That same thing. Yes or no? That same thing. Great. So angiodysplasia is equal to colon. That same thing. What is that? Yes, dilated submucosal arteries. Yes, submucosal arteries. Dilated submucosal arteries. On colonoscopy, what do you get to see? On colonoscopy, you get to see, yes, vascular tufts. Yes, vascular tufts. Radiating vessel. Yes, radiating vessel. Yes or no? Radiating vessel. Yes. Do you know, now I should not be speaking like this, but I have become so popular that I have my medical students in Pakistan also, in Afghanistan, in Kenya, Uganda. You can say there are many European countries also. Yes or no? There are many European countries. This thing that I could have got is just because I could concentrate on my clinical acumen now. Yes or no? If you see, yeah, I have gone to a next level now. So I have not only Indian students who are fan of me. Now I have students pan world. So I'm enjoying that privilege. Yeah. So colonoscopy, vascular tufts, and radiating vessel. What else you get to see? Remember that most common site. Most common site for this. Most common site. It is the cecum greater than ascending colon. Yes, cecum ascending colon. Yes, ascending colon. Cecum ascending colon greater than proximal jejunum. Yes. Proximal jejunum. Yes, proximal jejunum. Remember, what is the treatment of choice? Treatment of choice for them is angioembolization. If angioembolization fails, yes, we will go for what? Segmental resection. देखो, I have a group whose name is Telegram group whose name is Surgery Dada. You can join this group. I give all the information about my upcoming classes etc. on this group only. This is what is Surgery Dada. You can join this Telegram group, and any problem you have, any question you want to ask, you can ask me there. Okay. One very important thing about this angiodysplasia is I forgot to tell you, angiodysplasia is associated with two things. It may be associated with aortic stenosis, and students, this is a very famous question that 74-year-old went for defecation where he passed the stools with massive blood and and went in syncope there. What is the cause? Diverticulosis, angiodysplasia, 74 years. Yes, had a blackout episode. Blackout, very good. It's a Hyde syndrome because it's a combination of angiodysplasia. Remember, diverticulosis is the most common cause of bleeding. Yes, angiodysplasia is the most common cause of massive bleeding in elderly. Try to understand the word massive bleeding. Angiodysplasias bleed massively, diverticulosis don't bleed. They bleed commonly, but they don't bleed massively. So most common cause of massive bleeding in elderly, what is the answer? Yes, it is Hyde syndrome. Actually, this presentation is what is known as Hyde syndrome. Is that clear or no? So we have Hyde syndrome. So this is about the bleeding. Now again, miscellaneous about lower GI bleed. Investigation of choice, it is again endoscopy. What are the endoscopic options? We have colonoscopy. Remember two important points on colonoscopy. What is the length of colonoscope? Answer is 160 centimeter. Visualization up to, second question is visualization up to. Come on students, tell me, visualization up to. Answer is terminal 10 centimeters of ileum. Next is, when you do colonoscopy, you actually require a bowel preparation. Do you require or no? Bowel preparation. Yes. So bowel preparation, what is the grading? For bowel preparation? Can you tell me? Boston's grading is for bowel preparation. 1, 2, 3, 4. This is like Boston's grading is for bowels preparation. But बच्चे बस नाम याद रखना, MCH में पूछा हुआ है. Actually, I'm teaching the MCH students also. So meanwhile, I get carried away. So Boston grading is not that important, but remember, it is a grading for bowel preparation also. So colonoscopy. Then we have sigmoidoscopy. If you talk about sigmoidoscopy, again, what is the length of the scope? Length of the sigmoidoscope. What is the length? Answer is 60 centimeter. Use your surgical sense, students. S is 60 centimeter. The next is, if you talk about the length, the next thing is visualizes up to. Come on, tell me, visualizes up to. Answer is terminal descending colon, up to splenic flexure, yes or no? Then we have proctoscopy. Remember proctoscope. What is the length of proctoscope? Answer is 25. How I remember? 25. Rishabh is asking, investigation of choice for ischemic colitis. Answer is, bache, we don't go for both of them. We don't go for ischemic. Don't go for both of them. Yes, you can go for a CCT. We go for a CCT is a better option. We go for a CT. Colonoscopy is absolutely contraindicated for ischemic colitis. Colonoscopy is absolutely contraindicated. CT scan is sufficient to diagnose ischemic colitis. Colonoscopy, do you know why? Because there are three types of ischemic colitis. GST. Remember, G stands for generalized. Remember, GST wala GST, generalized. S for submucosal. Yes. and T for transmural. Transmural. Remember, if it is a generalized one, or if it's a submucosal, there is always a risk of perforation which can be induced by the scope. Therefore, colonoscopy is absolutely contraindicated. Where does it visualize up to? It visualizes up to what, students? Yes, distal sigmoid. Distal sigmoid. Apart from this, yes, very good, Brijraj. We get a thumbprint appearance. Apart from this, we have anal speculum. This is not a scope. It visualizes up to, yes, mid rectum, up to mid distal or mid rectum. Remember, what is the length of this? Length is 8 centimeters. So I will wind up this session here only. Remember, you can join this group Surgery Dada, where I actually tell about all the classes, and the only thing that you need to do is use the code Surgery Live. Use the code Surgery Live to access all my free courses running on Unacademy. Yes, you can enjoy this. This is a last moment bite which you can actually enjoy it. Yes, do join this group also, so that you have information. Tomorrow at 2 p.m. let me tell you, tomorrow at 2 p.m. when you join the group, tomorrow at 2 p.m. I am having a special class for sutures. I'm decided all small topics, and sutures, knots, and instruments. So that will be 2 session tomorrow and day after tomorrow, 2. Trauma is not done. Trauma I've revised. I'll revise again. Bache, all these important points I'll keep on revising again. This is on special. This is not on YouTube. This is on the special class. And for special class, you have to log on to Unacademy, download that app. Wherever prompted, use the code Surgery Live, or you can use the code Dr. Dixit also. It's same. Yes, and please access this. Please try to make maximum out of this. So I hope you enjoyed this session. I'll be getting much more interesting sessions of revision for you every day or every alternate day, based upon how I am available and free. Till then, continue with your preparation. Don't leave that spirit. Don't leave that hope that one fine day everyone will be on the other side of horizon. When a moron like me can do it, you people are very smart. Yes or no? So when I can do it, बच्चे, you can also. So don't get frustrated. क्या होगा, कुछ भी नहीं समझ में आ रहा है. जैसे भी होगा, the competition is between all of you. It's not between you and me. All of you are in the same boat, same page, same sufferings, same delightment, same energy level. Is that clear? So perform. Give your best. Don't think about how much you know, how much you don't know. Give your best. Till then, bye bye. A salute from me.